हेलो गाइस, वेलकम टू द नीट पीजी सीरीज। एंड आज हम डिस्कस करने वाले हैं सर्जरी का टॉपिक एब्डोमिनल ट्रॉमा। एंड द नोट्स विल बी शेयर्ड इन द ग्रुप on the telegram group. You can download the notes from there, and the name of the telegram channel is Pehel Free Neat PG Coaching, or you can download it from my channel, that is Dr Lalkrishna MULWANI Tata. So without further delay, let's get started. Abdominal trauma. So abdominal trauma is one of the common injuries which occurs and can be as serious, causing as death. So now we'll be seeing it in detail, which are important, the topics which are important for NEET PG. So let's see the mechanism first, how this injury occurs. So blunt abdominal trauma is one of the most common injuries, and the organ commonly involved is spleen, followed by liver, and lastly small intestine. So most common organ being injured is spleen. Then when it is a penetrating injury, then it is different. The most common organ involved is liver, followed by small intestine, and lastly it is diaphragm. And next is due to gunshot wound. In gunshot wound, it is most commonly injured organ is small intestine, followed by liver. If there is a deceleration injury, like in case of a car accident, then the duodenojejunal flexure, that is the DJ flexure from the ligament of triads, so that area is injured, so that will be affected. Then coming to seat belt syndrome, that is seat belt injury, so mesentery of bowel will be affected here. And lastly, overall most common injured organ is spleen again. So now coming to how do we work up these patients, how do we manage these patients. So first of all, in the case of blunt abdominal trauma, we have to first assess the vitals. So if the patient's vital is stable, then we can go for investigation of choice, that is CECT. Even we can go for a fast initial examination as fast. If that is negative, we may avoid doing a CECT, although it is the investigation of choice. And in case of hemodynamically unstable, like the pulse rate is very high or the BP is low, in these in these cases we go for fast or EFAST, that is extended focused assessment sonogram in trauma. So now we'll be seeing what is fast. We have already seen it in the last class when we were examining the lungs and the heart in the pericardium. Now we'll be just going through it quickly. So it is kept in the ultrasound room for emergency cases, and probe is placed at 6 places, not 4 places. Like in fast it is 4 places and EFAST it is 6 places. So starting from subxiphoid, the epigastrium, looking for cardiac tamponade, which we have seen in the last class. Then the right upper quadrant or right hypochondrium to look collection around the liver or the subhepatic space. In the left upper quadrant, left hypochondrium to look any collection around the spleen. Then the suprapubic area to look for collection in the pelvis around the bladder. So what are the advantages? It is quick, it can detect little as 100 ml of fluid. Disadvantage is it is operator dependent. So unless and until he is well trained, he cannot be giving us a valid report. Then coming to retroperitoneal injury, they can be missed, they cannot be seen on fast. Then as we have discussed that EFAST, where there is 6 places, 4 plus 2 in the thorax. Then false positive fast. If fast is positive, like fast has come out to be positive, that means there is some collection inside. Then we can directly take our patient for surgery, that is midline laparotomy, to assess and find out what the injury is. Even if the fast is positive and the patient's vital is stable, then for further details of the condition, we can take our patient for CECT. So that will give us a better picture, better idea of the injury, the severity of injury, the organ of injury, that can be much detailed way we can get from the CECT, since it is the investigation of choice. So we have to understand that if FAST is positive, if the patient is unstable, we'll directly take him to midline laparotomy for surgery. If the FAST is positive and the patient is stable, we can take the patient first for the CT scan, CECT, with IV and oral contrast depending on the need. And generally in trauma, we directly go for IV contrast, but if it is needed, we can also give oral, but it is generally avoided. So consider it as IV contrast, CECT, IV contrast, CECT whole abdomen IV contrast, and as per the report, the organ of injury, then we can take the patient for surgery or manage as per the report. Then further utilization, it can detect free fluid in the abdomen, lungs, and the pericardial and pleural space, and it will not detect less than 100 ml of fluid. So it also does not identify hollow viscous injury and cannot reliably exclude injury in the penetrating trauma. So it can also miss the injury in penetrating trauma. अगर चाकू ऐसा कुछ इंजरी है तो वो मिस भी हो सकता है, ठीक है. And sometimes we may need to repeat or supplement with other investigation, like as we have discussed CECT or chest X-ray, and it is unreliable for retroperitoneum as we have discussed. So what we have missed, for if there is hollow viscous injury, then a chest X-ray can give us a picture of air under diaphragm, that can be helpful. So here, in case of hollow viscous injury like stomach injury or intestinal injury, we can get a chest X-ray that will give us a good idea of air under diaphragm, which will give us a rough idea of hollow viscous injury if there is any perforation. Then for retroperitoneum, we'll have to go for a CECT examination. Otherwise, we'll not be able to give a diagnosis. And in case of penetrating also, we'll need a CT. So now just going through a flow chart, what we have discussed. So we'll just go through a physical examination, abdominal examination. Then if we are suspecting, we'll go for a FAST. If the patient on the FAST, if the patient has hemodynamic instability, then we'll go for surgery directly, exploratory laparotomy, midline laparotomy. And if the patient, there is no peritonitis, hemodynamically patient is stable, BP and vitals are stable, then we can go for a CT. If we have a hollow organ injury like stomach or intestine injury, then we can go for exploratory laparotomy or even diagnostic laparoscopy as per the availability of surgeon and the facilities. Then if there is no hollow viscous injury, hollow organ injury, then we will check if there is any solid organ injury or any other injury or free fluid. Then there could be a mesenteric injury, then we have to manage it accordingly. In case of solid organ injury, whether there is any pseudoaneurysm, arterial blush on CT scan, if that is there, then we may think of going for an interventional radiological intervention like angioembolization. And if it is more severe, more injury, even though vitals are stable, then we may have to go for a surgical management. Like in case of spleen, we may have to go for a splenectomy or a splenography, like that. And if it is very minimal injuries, then we can go for a non-operative management, like in grade 1 injuries. Now coming to penetrating injury. So penetrating injury, if the patient is stable, there is no peritonitis and is superficial injury, then we can think of CECT for examination and local wound care. If the patient is unstable, there is signs of peritoneum or something is coming out, like the omentum is coming out, or there is some bile staining, then we directly take the patient for surgery, that is midline laparotomy. And we have to remember that if there is something that is penetrating the abdomen and the patient has been brought to you in the emergency room with the object in the abdomen, like a knife or something, it should be removed under anesthetic or in the operation theater, where we have lot of facility to control hemorrhage in a better way. So it should not be done in the emergency room, in the casualty, so that the patient will not deteriorate or go into hemodynamic instability due to loosening of the bleeding area which was controlled by the object, so that when removed there will be loss of that control, so there will be increase in bleeding. So we have to not remove any object like knife in the emergency room. So now just going through the flow chart. So if the patient comes with shock peritonitis, evisceration of any of the organs, or hemodynamic instability, or free chest x-ray, free air on chest x-ray as we have discussed, like in penetrating injury or like hollow viscous injury, so we can directly take the patient for exploratory laparotomy. If the patient is stable, then we can think and consider about the location of injury, whether the injury is in the flank. If it is in the flank, then we'll go for a CT, abdomen and pelvis with along with contrast. It could be IV and plus minus rectal contrast. And if we have something positive, then we take the patient for exploratory laparotomy and repair, or even damage control surgery as per need. Then in negative or indeterminate case, we'll go for a serial examination, or the patient can be, if the patient is stable, then we can even discharge him after some observation. In case if there is an anterior-abdominal injury, again we'll go for CT scan after wound exploration, local wound exploration and care of the wound, and serial abdominal exams for 24 hours. If there is some facial violation, peritonitis or some injury inside, we'll again go for a exploratory laparotomy or a diagnostic laparoscopy as per required. Or if it is not there, if it is negative, indeterminate, then we can go for a serial examination, or if the patient is fine, then we can go for a discharge. And in observation, if we are finding there is some issue, then we can take the patient for diagnostic laparoscopy. Lastly, in case if it is a thoracoabdominal injury, then we'll go for a chest x-ray to confirm pneumothorax, a pericardial fast to assess cardiac injury, pericardial tamponade or injury to the heart muscle, and diagnostic laparoscopy to rule out any injury in the abdomen. So, and manage as per the findings. Now, when the fast is not available, then what we can do, alternative, that is diagnostic peritoneal lavage, which is not very commonly done nowadays, but it is important so that we can know it and use it in case we need it in emergency sometimes. So it is done when fast is not available, and it cannot evaluate retroperitoneal injuries. Okay, so as fast, similar to fast, it cannot evaluate retroperitoneal injury. So how do we do this? So first we put Ryle's tube in the empty to empty the stomach. So first we put the Ryle's tube, then we put Foley's to decompress bladder. So the stomach and bladder are decompressed and empty. Then we insert a needle just below the umbilicus and we aspirate. If there is 10 cc of blood coming out, then it is positive. Then we can take the patient for surgery. If less than 10 cc of blood comes out, then we can infuse 1 liter of NS or RL and then re-aspirate it. So if the aspirate has RBC, that is more than 1 lakh per cubic mm, or WBC more than 500 per cubic mm, amylase more than 75 international unit per liter, or presence of fecal matter like stool. So in any of these conditions like blood, so there is injury, hemoperitoneum, WBC, contamination, amylase or fecal contamination. Any of these cases it is positive, then we take the patient for laparotomy, so surgery. So now this was diagnostic peritoneal lavage. So just we'll go through it. What we do, पहले एक राइल ट्यूब डाल रहे हैं, स्टमक को एम्प्टी कर रहे हैं, फोलीज डाल रहे हैं, ब्लैडर को एम्प्टी कर रहे हैं, देन नीडल को हम एक डाल रहे हैं अराउंड 16 or 18 gauge needle in the just below the umbilicus and we aspirate. If there is 10 cc of blood coming out, we consider it as positive. Otherwise, we infuse 1 liter of NS or RL. Then we re-aspirate. If that has more than 1 lakh RBC or more than 500 WBC or more than 75 amylase or fecal content, in any of these cases, 4 of them, we take the patient for laparotomy. So we'll take the patient for surgery. Then now coming to the spleen. So spleen is the most common injured organ. So we'll be seeing it in detail. So spleen is the most common injured organ overall and is the most common injured in blunt abdominal injury and also in children. So when do we suspect? When there is injury on the left side on the lower ribs, that is 9 to 11th ribs. So bruising in the left lower chest wall or fracture of 9 to 11 ribs. So in these cases we consider there is splenic injury. Also we see Kehr sign. So if we raise the left lower limb, blood accumulates in the left dome of diaphragm, which causes referred pain to the left shoulder tip. So if there is a splenic injury, when the patient's left leg is elevated, पैर उठाएंगे लेफ्ट वाला तो ब्लड लेफ्ट डोम ऑफ डायफ्राम में जमा हो जाएगा और वहां पे इरिटेशन की वजह से लेफ्ट शोल्डर टिप पे पेन होगा. सो दिस इज केहर साइन एंड इज पॉजिटिव इन स्प्लेनिक इंजरी. Then coming to grades of splenic injury. So there are 5 grades. So this is understood by depth of laceration, or surface area of hematoma. So grade 1 is a most simplest injury, that is laceration less than 1 centimeter deep or subcapsular hematoma involving less than 10% space. We can see in the diagram. So laceration less than 1 centimeter or subcapsular hematoma less than 10%. Then 2, where the laceration is 1 to 3 centimeter and hematoma is 10 to 50%. That is 2. So laceration is 1 to 3 centimeter and 10 to 15% surface area of hematoma. And intraparenchymal hematoma of less than 5%. That is also a condition. Then 3, where the laceration is more than 3 centimeter deep or subcapsular hematoma more than 50% or more than 5% of intraparenchymal hematoma or ruptured subcapsular hematoma. So if it is of more than 5 centimeter, so that is grade 3. Then coming to grade 4, that is laceration to the segmental vessels or hilar vessel with significant devascularization. So as we can see in the diagram, there is around 25 to 75% of devascularization, active parenchymal bleed which is confined, pseudoaneurysm or AV fistula, okay, or segmental devascularization. So this is grade 4, and in grade 5 it is completely shattered or hilar with complete devascularization. So it is fully damaged and distorted. So vascular injury with active bleed into the peritoneum. So bleeding is coming out of the peritoneum, coming into the peritoneum. So it is called complete vascular injury, complete shattered spleen, complete devascularized spleen or shattered spleen. So this is grade 5. So now we'll just go through quickly about the management, grade wise management of splenic trauma. So first and foremost, we have to understand whether the patient is hemodynamically stable. If we are suspecting a splenic trauma, if the patient is stable, then we can do a CECT to confirm the grade of trauma. If the patient is hemodynamically unstable, then we'll have to go for a FAST to confirm, or a DPL, diagnostic peritoneal lavage. So we do a CECT in grade 1 to 3 and the patient is hemodynamically stable. Considering he is stable, then these grades 1 to 3 generally, especially 1 and 2, they are managed conservatively by serial examination and monitoring of vitals, and we can also go for serial 24-hour CECT, although this is not always needed. If the vitals are stable and the hematocrit is not dropping and it is grade 1 2 injury, we can also avoid doing this CECT. In case of grade 3 trauma, if we are suspecting there is a chance of increased injury or we are suspecting a deranged vital or loss of HB, we can repeat a CECT after 24 hours and we can take a decision after that. If there is increase in grade of injury on the repeat CT or contrast blush on CT, then we can go for an angioembolization If that fails, if angioembolization fails, which is an interventional radiological procedure, or the patient is unstable, then we can go for a surgery, that is splenography, and if required, even splenectomy. Then in case of grade 3 to grade 5, especially when the patient is hemodynamically unstable, we go for a EFAST, confirm that there is splenic injury, and they take the patient for laparotomy and splenectomy. So this has to be understood that grade 3 we have to be careful, because it can be stable also, it can be unstable also, and even after being stable there could be some injury inside which can be dangerous as time progresses. So serial monitoring of vitals, hemoglobin, hematocrit, and abdominal examination, clinical examination, these are very vital for saving the patient, because delay can cause loss of life. So we have to be careful. So grade 1 and 2 can be managed conservatively most of the time. Grade 3 may be managed conservatively or may need surgery sometimes. And initially before surgery, we can go for angioembolization. Grade 4 and grade 5 generally need surgery. But if it is a possibility, we can try for interventional radiological angioembolization in grade 3 and grade 4. If that fails or not available, we can directly go for a surgery, that is splenography or splenectomy. Then coming to what are the precautions which are needed after splenectomy, since spleen is a very vascular organ. So what can be the complication? Like hemorrhage is a very common complication, so it has to be taken care of. Injury to the pancreatic tail, which is in the splenic hilum, so that has to be taken care of while splenectomy or splenography. Turbid discharge in the drain that is rich in amylase, which could lead to pancreatitis, so we have to be careful. Hematological changes, what are the changes that are happening after splenectomy? So there will be transient changes like increase in WBC, RBC and platelet for the period of 2 weeks. Then permanent changes which are seen as the peripheral smear findings. So what are these findings? So basophilic stippling, oval jolly bodies, reticulocytes and hypersegmented WBCs. So these are some permanent changes. Now coming to what are the infections. So there is one infection, that is OPSI, that is opportunistic post-splenectomy infection, which is very dangerous. And it can occur in the first 2 years and more common in children than adults, and is commonly seen in splenectomy when it is done for hematological condition like sickle cell anemia. So what are the post-splenectomy complications? Like infection involved due to encapsulated organism are encapsulated. Which are they? So these are streptococci pneumoniae, pneumococcus or Haemophilus influenza. So these two organisms, streptococcus pneumoniae and influenza, can cause infection, and so they have to be prevented by vaccines. So it is given 2 weeks before in case of इलेक्टिव सर्जरी, पहले दे देंगे अगर इलेक्टिव है, और इमरजेंसी है तो पोस्ट ऑपरेटिव डे 1-2 में दे देंगे. और मोस्ट कॉमन कॉम्प्लिकेशन क्या है? मोस्ट कॉमन कॉम्प्लिकेशन तो लंग का कॉम्प्लिकेशन है, दैट इज फ्लोअर लंग कॉम्प्लिकेशन, एटेलेक्टेसिस और निमोनिया, collapse of lung or pneumonia. So these are the common complications after splenectomy. Then coming to the other common organ, that is liver trauma. So it is also one of the most common organs getting injured in the body, especially the blunt trauma, the second most common organs injured. So now we will be seeing the details of liver trauma. So first, what are the grades of liver trauma? So here we have 6 grades. So what are these? We'll see in detail. Grade 1, when the subcapsular hematoma is less than 10% surface area or laceration capsular tear is less than 1 centimeter. So we as same as earlier, less than 10% and less than 1 centimeter. Then grade 2, when the subcapsular hematoma is 10 to 50%, 10 से 50% है, और the hematoma, intraparenchymal hematoma is less than 10 centimeter and capsular tear or laceration is 1 to 3 centimeter and less than 1 to 3 centimeter deep and less than 10 centimeter in length. Then grade 3 hematoma, so it is subcapsular hematoma more than 50%, intraparenchymal hematoma more than 10%, and laceration depth more than 3%. So as we can see in the diagram, 1 to 3 centimeter deep, less than 10 centimeter depth hematoma, and 10 to 15% of subcapsular hematoma. And in grade 3, more than 3 centimeter, more than 10 centimeter, and more than 50%. So grade 3 trauma. Then coming to grade 4, when there is laceration with disruption of more than 25 to 75% of the hepatic lobe or 1 to 3 of the choanoid segments, then it is grade 4. So 25 to 75% of hepatic lobe disruption and active bleed into the peritoneum. These are some of the finding of grade 4 injury. In grade 5 injury, it is more than 75% of the hepatic lobe, more than 3 choanoid segment, vascular injury like juxtahepatic venous injury, retrohepatic vena cava, or central major hepatic vein. So all these vascular injuries. So this is grade 5. So we can see in the diagram more than 75% caval or central major hepatic vein injury. So these will be grade 5. And lastly is vascular avulsion. So if the vessels in the hepatic region are avulsed, the portal vein or the hepatic arteries, all these, if they are avulsed, then it could lead to grade 6 injury. Now, just going through the management, in grade 1 to grade 3, it is generally stable. So it can be managed conservatively by serial monitoring and serial hematocrit. Before management, also initially it will be the same. If the patient is stable, we'll go for a fast, and if the patient is stable, then if there is some finding in the fast, we'll go for a CECT, which is the investigation of choice. If the patient is unstable, then we'll take him for surgery urgently. In case of grade 5 to grade 6, we'll go for surgery. So what is the most important aspect of surgery? So it is 4 P's in liver trauma. So what that is: push or bimanual compression, Pringles maneuver, plug using Sengstein-Blakemore tube, and packing. So what are these? We'll see in detail. In grade 1 to grade 4 injury, that is Pringles maneuver, where we compress the hepatic pedicle containing the portal vein, hepatic artery, and the CBD at the foramens of Winslow. At the foramen of Winslow, which connects the greater sac and the lesser sac. Foramen of Winslow connects the greater sac and the lesser sac. If the bleeding stops, that means the bleeding is from there, from the portal vein or the hepatic artery branches. So we do a Pringles maneuver for 15 to 20 minutes, release the clamp after that to prevent hypoxic damage, and repeat if required. If the bleeding continues, then it is due to some other area like the hepatic vein tributary. So we'll do the next step, that is packing. So that is done by cutting the triangular ligament that is above the liver, which drops the liver from diaphragm. Then we pack the liver with gauze, Mbbs from above and below, and keep it there for 24 to 48 hours. So that will keep a pressure on that, having a tamponade effect, and the bleeding will stop. So what we did, we cut the triangular ligament काट दिया, liver नीचे आ गया, we packed liver को pack कर दिया by Mbbs above and below, and it is kept for 24 to 48 hours. So that will have a tamponade effect, that is pressure effect, and bleeding will stop. Then coming to, if there is any vascular injury, if the vascular artery is injured, we'll go for a repair. If that is not possible, then we will have to ligate it. In portal vein injury, we'll directly repair it. In common bile duct injury, we'll repair it over a T-tube, that is a stent. T-tube stent. T-tube is a T-shaped tube which is repaired, and the T part of the tube is brought out from the abdomen from a separate incision. So, and this plug, that is the Sengstein-Blakemore tube, this is used in case of bleeding, and to compress a bleeding from the viscera, that is the liver, in case of penetrating injury especially. So that will be helpful for that. And pushing compression by bimanually will also stop bleeding in case it is minor. So these are the 4 P's. Now coming to complication, what are the complication? So bleeding, abscess, stricture or AV malformation. So these are the complications. Also we can go ahead with angioembolization if it's a minor injury like grade 3 or grade 4 injury, depending on the scenario, situation and the hemodynamic stability and the availability of the apparatus for angioembolization, which is a specialized interventional radiological procedure. Then coming to next, just going through the flow chart. So in bleeding hepatic trauma, if there is minor bleeding, it can be managed by topical hemostatic agents, suture hepatography, like just suturing the bleeding area, so hepatography or like splenography it was, or electrocautery or argon beam. If there is a major bleeding, so perihepatic packing, resuscitate the patient again simultaneously. If bleeding is controlled, we can go for a damage control surgery and consider angioembolization if required, as we have discussed, and along with that ICU resuscitation. If the bleeding is still uncontrolled, we go for a Pringle's maneuver. If the bleeding is controlled, we go for a selective vessel ligation with omental packing. So this is special, which we have to understand. What is that? Selective vessel ligation. So we ligate the vessel and pack it with omentum. So if the bleeding is controlled, we go for a angiography, understand from where it is bleeding, and ICU resuscitation. If the bleeding is still going on, then we'll have to go for a selective hepatic artery ligation, as we have discussed. Then further take the patient for resuscitation in ICU. If the bleeding is still uncontrolled after Pringle's maneuver, then we'll go for a packing, that is perihepatic packing. And if that manages, then we'll go for a resuscitation. If still it is uncontrolled, then we have to consider vascular isolation with shunting procedure. So this will be a specialized procedure, vascular isolation with shunting, and then we'll take the patient for ICU resuscitation. So this is the flow chart for management of uh, hepatic injury, hepatic bleeding. Then coming to mesenteric injury, which is most commonly seen in seat belt injury, seat belt syndrome, when the patient has worn a seat belt and there is sudden accident, it will cause a longitudinal tear and it can also cause transverse tears. So in case of longitudinal tears, so the bowel ischemia is not there. So there is no bowel ischemia, as the adjacent side branches, they will be supplying the blood and there will be less likely chances of necrosis or loss of bowel. So we can just repair the longitudinal tear of the mesentery and manage the patient by that. If there is a transverse tear that is parallel to the bowel, then entire supply is cut and the segment of bowel goes for necrosis. So it will be gone. So we have to go for a resection, and if the patient is stable, we can go for anastomosis. If the patient is not stable and the patient is having the deadly triad of trauma, that is uh, coagulopathy, hypothermia and all that features, then we'll have to go for a damage control surgery, that is make a stoma or a drop and clip approach. Clip and drop approach. Either we can make a stoma or we can go for a clip and drop approach and manage the patient in the definitive period, during the definitive period. Definitive surgery after resuscitation. Then coming to stomach. So in stomach, it is the most commonly involved due to penetrating injury. So if the NG tube, nasogastric tube, it is showing blood, then there will be chance of gastric injury. After examination and investigation, we can take the patient for surgical repair depending on the hemodynamic stability. And we have to be careful that we do not miss the stomach exit injury, because there is sometimes possibility that the injury can cross the posterior wall also. So we have to be careful while considering the injuries of the stomach, that we do not miss the posterior or the exit injuries. So this was all about stomach injuries. And now we'll be just going through about from the duodenum and pancreatic injuries. So these duodenal injuries, they are generally associated with pancreas. So they are injured together, and investigation is CECT whole abdomen, especially understanding the patient is stable. Otherwise, we have to directly take the patient for laparotomy. So in case only sign is gas or fluid collection in the retroperitoneum or leakage of oral contrast, this is the finding. So we have to understand that in case of duodenal injury, the only sign we get is gas or fluid collection in the retroperitoneum or leakage of oral contrast. Then if there is just a duodenal hematoma, so if there is just hematoma collection, then we'll keep the patient for NPO, nil per oral, and give bowel rest. That will manage the case, especially when the hematoma is not increasing and is controlled. In case of first, second, and third part of first, third, and fourth part of duodenum, we'll repair it by sutures, like in case of small bowel. And especially in the second part of duodenum, it will need a damage control surgery. So it is a very severe injury, so it will need a damage control surgery in the form of triple tube ostomy. So we go for a triple tube, that is decompressive gastrostomy, decompressive duodenostomy, and a feeding jejunostomy. So gastrostomy, duodenostomy, and jejunostomy, and is done after repair of the second part of the injury. So this three triple tube ostomy is done by repairing and making gastrostomy, duodenostomy, and jejunostomy. In case of perforation, we can go for a omental patch repair, Graham's patch repair, depending on the size of injury. Then in case of pancreatic injury, the most important point that we have to consider is whether there is injury to the pancreatic duct. If it is there, then the prognosis is poor. That means it is very bad injury. Again, investigation will go for a CECT, and depending on the report, if the injury is present but the main pancreatic duct is not affected, it is normal, then the patient can be managed conservatively by monitoring IV fluids, antibiotics, and serial examination of reports, blood reports, HB hematocrit, and vitals. In case the injury is in the body and tail, then we will see whether the injury is to the left of superior mesenteric vessel. If it is in the left, then the patient needs a distal pancreatectomy or closed suction drainage. So the patient will need a distal pancreatectomy, which is a surgical method, surgery, or a closed suction drainage. In case it is to the right of the superior mesenteric vessel, we can again manage our patient by conservative treatment. Then if the injury is to the head, then we'll have to go for a Beggar procedure, that is a DPP, duodenal preserving pancreatic head resection. DPPR, that is duodenal preserving pancreatic head resection. Just going through the protocol, that is the flow chart. So if there is a pancreatic injury, we check complete exposure of the pancreas. If there is any of these deadly triads, then we go for a damage control, that is control hemorrhage, external drainage of the pancreas, and temporary closure. If that is not there, then we'll go for a check, CECT examination, pancreatic duct is not involved. So it can be managed conservatively, or at the most we may need external drainage with closed suction system. If there is some involvement, then we do determine location of injury. It is the pancreatic head or uncinate or right of the superior pancreatic vessel. Then in case of a head or duodenal injury, then we go for a pancreaticoduodenectomy. In case of external drainage, in case of minor injury, we go for external drainage, securing the distal feeding access. Then in case of a pancreatic neck or body injury to the left, on the left side, then the mesentery injury to the pancreatic neck or body to the left of the mesentery, that is superior mesenteric vessel, we go for a distal pancreatectomy and external drainage. So hope it has been understood. The pancreatic injury, I can understand it is slightly complicated, and although this is a protocol, this is not hard and fast. We have to understand and take the consideration of the scenario. We have to understand that we have to consider the vitals, we have to consider the stability of the patient, hemodynamic stability, and then take the decision. If the patient, if there is an injury but the patient is stable, then there may not be need of a surgery. We have to consider the severity of injury, we have to monitor the patient for some time. Initial management protocol, initial management of conservative plan may convert to a surgery if the patient deteriorates. So we have to be careful. We should know what are the possibilities, we should know what are the options, we should know what are the surgeries which can be done in case of all the injuries, and then we can manage our patient better. So this was all about pancreatic injury, and for any doubts let me know in the comment section. And keep studying, keep growing, never give up, because great things take time. And please like and share and subscribe my channel, and see you soon in next video. Thank you.